Hello, everyone, and welcome to our module on hypogonadism. Hypogonadism refers to decreased activity of the gonads, either the ovaries in females or the testes in males. And just like other endocrine disorders, hypogonadism may be either primary or secondary. Primary hypogonadism refers to a disorder of the gonads, where either the ovaries or testes fail. Secondary hypogonadism refers to a problem with the hypothalamus or the pituitary gland so that there is loss of LH and FSH to stimulate the gonads. Let's talk about male hypogonadism first. In any form of male hypogonadism, the testosterone levels will be low. That's the defining feature of hypogonadism. However, in primary hypogonadism, the problem is with the testes, so the LH and FSH levels will be increased because the pituitary gland is trying to drive the dysfunctional testes to make more testosterone. In your textbooks, this form of hypogonadism is often described as hypergonadotropic hypogonadism. It's called hypergonadotropic because the gonadotropes, LH and FSH, have their levels increased. In secondary hypogonadism, testosterone levels are also low, just like in all forms of male hypogonadism. However, in this situation, the LH and FSH levels are low or normal, but they are not increased. And this is often described as hypogonadotropic hypogonadism. The symptoms of hypogonadism vary with the age of onset. Before puberty, if the testes are underactive, this will lead to a failure to undergo puberty normally. Normal puberty depends on the testes producing lots of testosterone. If they cannot, puberty will not occur normally. In the adult, the symptoms include decreased energy, decreased libido, which is sexual desire, and infertility. You need testosterone for normal production of sperm. And then finally, if hypogonadism in the adult male goes untreated for years, this can lead to loss of sexual hair, muscle mass, and even bone density. Shown on the screen are some select causes of primary male hypogonadism. These are all problems that involve the testes, not the pituitary gland. Klinefelter syndrome is a genetic disorder that I talk about in the genetics section. Those males typically have underdeveloped testes. Myotonic dystrophy is a trinucleotide repeat disorder that I talk about in the genetics section. It also typically leads to underdeveloped testes. Swyer syndrome is gonadal dysgenesis in the male. Obviously, if the gonads don't form normally, the male will have primary hypogonadism. And then finally, mumps can involve the testicles and can lead to damage to the testes. This can lead to primary male hypogonadism. Shown on this slide are select causes of secondary hypogonadism. They all involve the pituitary gland and the hypothalamus. Pituitary tumors and pituitary apoplexy, which is hemorrhage into the gland, can cause secondary hypogonadism, and I talk about both of these disorders in the endocrine video on the pituitary gland. Kallmann syndrome is a GnRH deficiency that occurs in association with anosmia. This also can cause secondary hypogonadism, and I talk about Kallmann syndrome in more detail in the endocrine video on reproductive hormones. Now let's talk about female hypogonadism. So this refers to underactivity of the ovaries and insufficient production of estrogen and progesterone from the ovaries. So in primary hypogonadism involving the female, estrogen levels are low, but LH and FSH are increased. In secondary hypogonadism, estrogen levels are also low, but LH and FSH are low or normal. Now, the confusing thing about female hypogonadism is we usually don't talk about female hypogonadism. Instead, we talk about amenorrhea, because if the ovaries are underactive in women, the main symptom that is seen is amenorrhea. So instead of talking about primary and secondary hypogonadism, we often talk about amenorrhea. And then to make it even more confusing as a medical student, we usually talk about amenorrhea as being primary or secondary. So primary amenorrhea is failure to menstruate by age 15. Secondary amenorrhea is a cessation of menses after menses were occurring normally. And there are many causes of primary amenorrhea that involve either the ovaries or the pituitary, and there are causes of secondary amenorrhea that involve the ovaries or pituitary. This makes understanding ovarian or female hypogonadism a little more complicated than the male version. Let's talk about primary amenorrhea first. There are a number of pituitary disorders that can cause primary amenorrhea, and many of these are similar to the pituitary problems that can cause hypogonadism in males. So any cause of hypopituitarism can cause primary amenorrhea. So can Kallmann syndrome, which is a GnRH deficiency. However, Kallmann syndrome has a 5-to-1 male ratio, so in a board question, it's unlikely to be described as a female with primary amenorrhea. And then there are a number of ovarian problems that can cause primary amenorrhea. Turner syndrome is the most common cause of primary amenorrhea. In Turner syndrome, girls have gonadal dysgenesis, and I talk about this in a video in the genetics section. Polycystic ovarian syndrome, when it occurs in adolescence, can also lead to primary amenorrhea. In PCOS, there is an excess of androgen production in the female, and I talk about PCOS also in a video in the endocrine section. And then finally, there are some anatomic disorders which can cause primary amenorrhea. In these disorders, the pituitary gland and the ovaries are working just fine, but the uterus is abnormal, so menstruation does not occur. The classic example of this is Mullerian agenesis, where the female is born with an absent vagina and uterus. So let's talk about Mullerian agenesis, which is also called Mayer-Rokitansky-Kuster-Hauser syndrome. Good luck remembering that name. In this condition, there is underdevelopment of the Mullerian system, which is the embryologic system that leads to development of the internal genitalia in the female. I talk about the Mullerian system in more detail in the video on genital development. In this syndrome, girl children are born with congenital absence of the upper vagina, and usually there is no cervix or uterus. These are all the structures that derive from the Mullerian system. As a result of not having a uterus, these girls will not menstruate at puberty, and therefore they will have primary amenorrhea. They will, however, have normal secondary sexual characteristics develop at puberty. For example, they will develop breasts and pubic hair normally, and this is because their ovaries are just fine and functional, so is their pituitary gland and their hypothalamus. They have normal hormone levels. The reason they are not menstruating is purely because of an anatomical absence of the uterus. Now let's talk about secondary amenorrhea. So this is a situation where a female begins menstruating normally at puberty, but then stops menstruating at some point later in her life. Common cause of this condition is pregnancy. Women who are pregnant do not ovulate, and the embryo implants in the uterus, and this leads to secondary amenorrhea. One of the things you always need to exclude if a woman presents with menstrual irregularities, including amenorrhea, is that the woman could be pregnant. Menopause is also another cause of secondary amenorrhea. Any cause of hyperprolactinemia will lead to secondary amenorrhea, and a prolactin level is often checked in women who are not menstruating. And then finally, thyroid disease can cause a woman to stop menstruating. Both hyper and hypothyroidism can lead to amenorrhea. Women who have thyroid abnormalities do not ovulate normally. There are multiple mechanisms for this. It involves both the pituitary and the ovaries. Some other selected causes are shown on this screen. Patients taking corticosteroids or patients who have Cushing's syndrome will not menstruate. Cortisol suppresses GnRH, so these patients have low LH-FSH levels and low estradiol levels. Cirrhotic patients develop hypogonadism. Males who are cirrhotic can develop hypogonadism, and females can also stop ovulating. This is because when the liver is cirrhotic, it disrupts hormone metabolism. The liver does much of the metabolism of hormones like estradiol and testosterone. As a result, the levels of testosterone, estradiol, and even prolactin can fluctuate in patients who are cirrhotic. This often disrupts the menstrual cycle. And then finally, spironolactone is a classic drug that often leads to amenorrhea in women who need to take it. It has anti-androgen effects, so this disrupts estrogen and androgen balance. It also can stimulate progesterone receptors. It has a chemical structure somewhat similar to progesterone, so by mimicking progesterone, it stops menstruation. Just like Mullerian agenesis is an anatomic cause of primary amenorrhea, there's an anatomic cause of secondary amenorrhea called Asherman syndrome. In Asherman syndrome, women develop uterine adhesions, usually following uterine surgery, and the adhesions and fibrosis can involve the endometrium, and this can disrupt menstruation. These women are often infertile because of the disruption to the endometrium, and they also develop secondary amenorrhea. 90% of cases result as a consequence of a surgery called uterine curettage. Uterine curettage is part of a procedure called the DNC, where the cervix is dilated and the uterus is scraped with a curette. When this procedure results in damage to the regenerative layer of the endometrium called the basalis layer, this will lead to a failure to menstruate. In other words, the endometrium will stop growing normally and the woman won't menstruate any longer. A DNC is often done after a woman has pregnancy or miscarriage to remove tissue left behind, and sometimes it leads to Asherman syndrome. And the key point here that you want to remember for step 1 of your boards is just like in Mullerian agenesis, in Asherman syndrome, the endocrine system is working just fine. The ovaries are fine, the pituitary gland is fine, so all the hormone levels will be normal. This is purely an anatomic defect. Asherman syndrome can be diagnosed through a test called a hysterosalpingogram. In this test, a dye injector is inserted into the cervix, and dye is injected to fill the cervix and uterus. If adhesions and fibrosis are present, the dye will not fill the structure normally. And you can see an example shown in the screen here. Dye is not filling this area right here. That's evidence of adhesions. Another potential cause of secondary amenorrhea, meaning a woman who stops menstruating after she had been menstruating normally, is primary ovarian insufficiency. It's also called premature ovarian failure. This is basically menopause that occurs at a very early age. It is an example of hypergonadotropic hypogonadism like we discussed before. It usually occurs before age 40, and the clinical features are similar to menopause. They include things like amenorrhea, but also hot flashes and vaginal dryness. Importantly, on workup, what you will find is that the FSH level is elevated and the LH level is elevated, but estrogen levels are low. All of these features are evidence of the ovaries failing to produce estrogen and the pituitary gland driving up the levels of the gonadotropins to try and stimulate the ovaries. This is a classic board question to describe a woman with amenorrhea and symptoms of menopause at an early age, to show you the hormone levels and have you think it can't be menopause because she's young. There is a phenomenon called premature ovarian failure where these symptoms occur in younger women. The workup of a woman with secondary amenorrhea is not something you're expected to know as a first or second year medical student, but I'll just briefly mention the important diagnostic tests because that can help you to understand better all the potential causes. So an HCG level is often measured to exclude pregnancy. A prolactin level is often measured to exclude any type of hyperprolactinemia. TSH is measured to look for thyroid disease. FSH levels are usually measured because high FSH is seen in ovarian failure, and sometimes a brain MRI is ordered to exclude a pituitary mass. I'll finish with this slide on a condition called functional hypothalamic amenorrhea. This is a common cause of secondary amenorrhea, especially among younger women. In this condition, there is decreased GnRH secretion from the hypothalamus. That's why it's called hypothalamic amenorrhea. The serum estradiol levels will be low, and the levels of LH and FSH will be low or normal. This often occurs in women who are under a great deal of stress. It also occurs in women with eating disorders or women who exercise excessively, or sometimes women who lose a significant amount of weight. And this is a picture of a stressed out college student here on the screen to remind you of the type of person who often develops this condition. And the key thing to remember for step 1 of your boards is it's going to be a younger woman who stops menstruating under a great deal of stress. And you want to remember that the problem starts in the hypothalamus with decreased GnRH secretion. And that concludes our video on hypogonadism.